I am presenting in a, I'll say some things about our organization, but I just want to start off by saying I was scheduled to present later this afternoon, but due to the hurricane, here I am. And because of that, and because I knew that this was the healthcare reform piece of the forum, I decided to change my remarks to address the bills that we're facing. And so my presentation is now handwritten and different than when I actually arrived in Kentucky yesterday. So I will be reading it a little bit more than I tend to do with my typical presentations. All that said, I want you to know that we consider Citizens Council on Healthcare to be one of the only things that stands between you and socialized medicine in this country. Our mission is to support patient and doctor freedom, medical innovation, and the right, your right, to a confidential patient-doctor relationship. We agree that there are problems with the healthcare system as it stands today, that there are no perfect healthcare systems. There are just healthcare systems that are more patient-centered, patient-friendly, ethical, and cost-conscious, motivated. We are concerned very much for where the 1973 HMO Act has brought this country in giving the power of healthcare over to HMOs through $375 million to develop them over the entire country. That was Senator Ted Kennedy's bill, and it was passed, or it was signed into law by Republican Richard Nixon. And that along with Medicare is why we are where we are here today. So I decided to talk about the bill. And so, as you probably know, on November 7th, the U.S. House passed a 2,015-page healthcare reform bill, H.R. 3962. Most Americans have no idea what's in the bill. Most Americans would have a very hard time understanding what the bill actually means. After it was passed by the slimmest of margins, 220 to 215, Congresswoman Louise Slaughter said at a press conference held by Speaker Nancy Pelosi the following: "Once the American people finally learn what's in the bill, they're going to love it," end quote. I disagree. And while I'm glad that Representative Slaughter acknowledged that this bill was passed by the House without the informed consent of the governed, I believe that once the American people find out what's in the bill, they will not believe that it is possible that anyone in leadership thought that citizens would not only support it, but love it. Well, let's look at the bill. I put together a list of just 6 items of the many in the bill that we believe will endanger the individual freedom, healthcare choices, personal security, medical privacy, and hard-earned incomes of American citizens. So, number 1, the individual mandate. The bill requires that citizens purchase health insurance or pay a fine. Jail time of 1 to 5 years, according to the IRS, is also possible. On Wednesday, Jake Tapper at ABC News tried to pin the president down on his position on this proposed requirement of jail time. While the president wouldn't say a definitive yes, he also refused to say a definitive no. Thus, President Obama, I believe, supports jail time. Back in 1994, a CBO report on Hillary Clinton's mandate proposal stated that the federal government has never required citizens to purchase anything as a requirement for citizenship. This bill would change that. But also importantly, the mandate by itself would nationalize healthcare. What the government mandates, the government must define. What the government defines, the government controls. Every aspect of insurance and medical care would eventually come under federal control as a result of the mandate alone. Already the bill demands that we purchase acceptable coverage, not the coverage or the policy we want, not the price we can afford, but the coverage that the government decides we must have and that will keep us out of jail. Number 2, the public option. The public option is really a mechanism to install a single-payer system in America. Since Americans would never accept single-payer, the public option begins small and limited. But once employers realize that paying the 2 to 8% fine and getting rid of their entire HR department is cheaper than covering their employees, most of the public will be stuck with the so-called public option. Furthermore, the bill essentially eliminates individual traditional insurance policies. You won't be able to buy them as an individual. I believe the public option is meant primarily to solve the impending Medicare insolvency crisis. If a single-payer system is in place by 2017, the year that Medicare trustees say Medicare becomes bankrupt, then Medicare can be rolled into the public option and, quote, saved. This would eliminate the political threat that members of Congress now face if they are still in office in 2017. Number 3, the National Health Insurance Exchange. The exchange will rule over all things insurance, including what plans will even be allowed in the exchange. And since health care through the public option can only be purchased through the exchange, and because premium credits can only be gotten through the public option, any health plan not in the exchange will not be around for very long. Thus, the exchange reminds me of the controversial regional alliances in President Clinton's health plan. Our organization helped to defeat the Minnesota Health Insurance Exchange proposed by Governor Tim Pawlenty. And needless to say, we are not pleased to have to look at it again in the national proposal. Number 4, comparative effectiveness research. The stimulus bill provided $1 billion for comparative effectiveness research and $19.5 billion for the creation of a national health information network. The system, as envisioned, will contain everyone's medical information. And because the HIPAA privacy rule is actually a no privacy rule, allowing government and others to access our medical data without our consent, citizens of this country will become involuntary subjects of comparative effectiveness research, which could then be used to deny them access to healthcare services. The House bill, H.R. 3962, plans to create a Center for Comparative Effectiveness Research. Page 742 of the bill says that the center will, and I quote, conduct, support, and synthesize research with respect to the outcomes, effectiveness, and appropriateness of healthcare services and procedures in order to identify the manner in which diseases, disorders, and other health conditions can most effectively and appropriately be prevented, diagnosed, treated, and managed clinically, end quote. This presumes that government can do a better job of making decisions about patients than doctors can. It also presumes that patient care can be standardized, but I assure you, as a nurse who has worked with many patients, patients are as different as their DNA, their preferences, their willingness to comply with any treatment, their reactions to treatments, and a whole host of other factors. Government advisory panels and a 19-member commission of political appointees will be established. Hundreds of millions of dollars will be poured into a comparative effectiveness research fund, which will be funded by a $2 per capita tax on insurers and passed on to citizens in the form of higher premiums. Concerned members of Congress have tried to prohibit this research from being used to ration and deny healthcare services. Twice they were rebuffed, and then language was accepted in the Energy and Commerce Committee. But when the House bill emerged, the anti-rationing language that had been accepted had been eliminated. In its place is a subtitle that still says, essentially, no rationing. But the accompanying statutory language no longer says any such thing. Instead, it says the following: nothing in this section shall be construed to make more stringent or otherwise change the standards or requirements for coverage of items and services under this Act, end quote. This is essentially doublespeak. Through this bill, HHS will be authorized to define an essential benefit set. The essential benefit set will only provide payment for, and I quote, items and services that are in accordance with generally acceptable standards of medical or other appropriate clinical or professional practices, end quote. This statement on page 110 is subject to broad and arbitrary interpretations. In addition, on page 535, the bill says that payment will be determined by the Secretary's definition of clinical quality measures, so government will decide. Finally, on page 1011 of the bill, a new Inspector General will be appointed to look for fraud and abuse, not only in public programs, but in the private industry. And it will be those terms will be defined by the Inspector General, because they are not defined anywhere else. So what if the Inspector General decides that the care you need and want does not meet the government's comparative effectiveness standards? Thus is fraudulent, wasteful, or abusive of healthcare resources. After all, eliminating fraud and abuse is the way that Congress intends to cut $400 to $600 billion from Medicare. Thus, we see a significant threat of healthcare rationing and treatment denial in this bill. Number 5, National Patient ID and Tracking Number. H.R. 3962 requires a machine-readable health plan identification card. The card will be used to determine, at the time of care, the patient's eligibility for specific services by a specific provider at a specific location. Thus, every patient must present a federally approved patient identification card for access to healthcare services. This National Patient ID number is very controversial. The unique patient identification number authorized in 1996 by HIPAA has never been implemented because of the sharp disapproval by the public. The card proposed in 3962 will not only be required to access care, it will reveal a patient's insured or uninsured status, and it will be used to link and tag all the private data of patients in the National Health Information System for analysis, research, and profiling of doctors and patients, all without consent. And number 6, taxes, fees, and fines. Not only will there be fines on individuals who don't purchase health insurance and employers who don't provide it, there will be higher premiums to pay. Higher premiums to pay for the addition of 36 million uninsured people and the insurance subsidies of everyone who is under 400% of the federal poverty guidelines. The higher premiums on everyone over the 400% of federal poverty guidelines is essentially a tax. It's a huge transfer of individual wealth to government and to health plans. And yes, there will be taxes on high-cost plans, except for those held by members of Congress, as well as higher taxes to pay for all the expansion of Medicaid. And there will be taxes on medical device manufacturers and pharmaceutical companies and high-income individuals. But the largest tax will be on the middle class, who will find that there are no protections for them in law. There will be no limit to what they can be charged for health insurance, and they'll be forced to buy a policy or face jail time. And when comparative effectiveness research is used to deny or ration their healthcare services, they'll have fewer dollars to buy it for themselves. And perhaps, just as Congress today forbids cash payments by senior citizens for care that Medicare denies, all citizens may be denied the right to pay cash for care denied through this bill. This, of course, is unconstitutional, but as I said, in Medicare, it's already the law. Now let me just point your attention for a moment to the Wall Street Journal of today. Perhaps some of you have had the opportunity to read the op-ed section. What Health Reform Will Do to My Insurance by Andrew R. Hines, who starts out the column by saying, I'm a registered Democrat living in New York City and I buy my own health insurance. He says that he is preparing for a life without health insurance. Andrew has a plan, a hospitalization plan that costs him $2,000 a year. Because New York has the same type of law that this bill is proposing to mandate across the country, for an individual in New York, the cost of health insurance is $13,000. Andrew has decided to spend $2,000 for a hospitalization plan instead of the prepaid healthcare HMO plan in order that he can afford it and that he can spend the additional $11,000 on any doctor's visits that he may have. He says at the end of his article that I realize that we who buy our own health insurance are a fairly small percentage of the market, but there are millions of us. Millions more may have an employer-based plan today, but not tomorrow. So as I prepare for the winter of my disinsurance, at least I'm not alone. So this is the kind of thing that people who know what is happening are worried about. And Americans need to ask themselves, is this the kind of healthcare system outlined, as I have outlined, that they really want? Do the 6 items that I detailed belong in a healthcare system in a free society? I don't believe they do. Instead, I believe that this is tyranny in the making. This healthcare debate, like the debate 15 years ago, is not primarily about healthcare. It's about life and liberty and individual choices. As John Gasky, a professor at Notre Dame and a registered Democrat for the last 20 years, wrote Investor's Business Daily in September, this is not about healthcare ultimately, it's about the long-planned socialist takeover of the United States, end quote. Americans should not be swayed by false assurances and platitudes about these bills. Americans must look beyond the rhetoric and see what the words really say. Look at the details, look at the definitions. Listen to the words and see if they mean what you think they mean. For instance, universal coverage is a promise of access without a guarantee of anything. Coverage does not equal care, as many a Canadian will tell you. In addition, the $1.4 trillion spending spree does not equal, as it is said, a reduction in the federal deficit. Those dollars have to be paid for. Healthcare quality, what does that mean? Do you ask what that means when someone says the word quality, or do you just assume it's what's in your head? Because it's not true. Healthcare quality has come to mean physician compliance with however the government wants them to do medicine. And then, lastly, they say it's a budget neutral bill. But even if you believe that it could possibly be budget neutral after spending $1.4 trillion, it will not be budget neutral to your own pocketbook. If this bill passes into law, citizens will have less money to pay for anything else in their lives. H.R. 3962 is a threat to patient care. It's a threat to our freedom, our future, our prosperity, and our right to life, to decide when it ends. What Americans need is a healthcare system befitting a free society, a system where individuals own lifelong, portable health insurance policies disconnected from their employment, a system where the insurance is true insurance, like hospital insurance, not prepaid health care. A system where health insurance provides defined contributions, not defined benefits that can be haggled over. A system where cash payments, including health savings accounts for routine and minor expenses, bring the price and the cost of care down to the level of individual pocketbooks. A system where true charity is available for the truly needy. A system where the patient-doctor relationship and the Hippocratic ethic is protected. A system where students want to become doctors and doctors want to stay doctors. A system where patient data and healthcare dollars are controlled by patients. And a system where patients are cared for and cared about and patient trust is preserved. H.R. 3962 will not do this. H.R. 3962 will bring socialized medicine and socialism to the shores of America. That is not my vision for healthcare. That is not our organization's vision for healthcare. And I hope that that is not your vision for healthcare or for America. Thank you.